Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. The objectives or the aims of the fifth lecture of acute inflammation are to know the 4 possible outcomes of acute inflammation and to learn the roles of various chemical mediators of acute inflammation. What is the fate or outcome of acute inflammation? The outcomes of acute inflammation are affected or modified by the nature and intensity of injury, the site of tissue affected or tissue involved, and by the host responsiveness to the injury. Acute inflammation has one of the 4 outcomes. First, resolution. Second, suppuration. Third, organization and scarring, or healing by fibrosis. And fourth, progresses to chronic inflammation. The first outcome of acute inflammation is resolution. Resolution means complete restoration of inflamed tissue to normal structure and function. Resolution occurs when there is no or minimal tissue damage and in tissue that is capable of regenerating. The sequences of resolution start by lymphatic drainage of acute inflammatory exudate into the regional lymph node. Then phagocytosis and clearance of cellular debris, necrotic tissue, and microorganisms by macrophages. In acute inflammation, neutrophils predominate in the tissue during the first 6 to 24 hours, causing destruction of cells and tissue by releasing of proteolytic enzymes. Neutrophils are short-lived. They die by apoptosis and disappear within 24 to 48 hours, and later on they are replaced by macrophages, which appear in the tissue after 24 to 48 hours. Macrophages survive longer than neutrophils, and they are more powerful scavenger cells in acute inflammation. They are responsible for the clearance of necrotic tissue and cellular debris. And later on, there is regeneration of damaged cells, and the tissue returns to normal structure and function. Example of resolution that occurs in lobar pneumonia. Lobar pneumonia, which is an acute bacterial infection with inflammation of one lobe of the lung. This is microscopic histologic features of lobar pneumonia, in which the alveolar spaces are filled by acute inflammatory exudate, rich in neutrophils and fibrin. The alveolar septa are intact and contain dilated congested blood vessels. This is lung tissue returns to its normal structure and function after resolution of lobar pneumonia. The alveolar spaces are cleared from inflammatory exudate, and alveolar septa are intact. Their dilated and congested blood vessels return to normal. The second outcome of acute inflammation is suppuration with pus formation. Sometimes acute inflammation is complicated by a secondary bacterial infection, such as biogenic bacteria, with pus formation, especially in cases without treatment. Pus may be formed either as a diffuse involvement in the tissue or as a localized collection of pus in the tissue forming abscess, or pus formation on the surface of a skin wound, or as pus collection within the body serous cavity producing empyema. This picture shows diffuse formation of pus in the tissue. This is abdominal cavity with a diffuse yellowish layer of pus covering the peritoneal surface. There is diffuse involvement of peritoneum by pus. This picture shows a localized collection of pus within the lung with abscess formation as a complication of acute bacterial pneumonia without treatment. This picture shows a collection of pus within the abdominal cavity or peritoneal cavity causing empyema. The third outcome of acute inflammation is organization and scarring, or healing by fibrosis, in which there is replacement of necrotic tissue by granulation tissue, which is a tissue of healing, and it is formed by ingrowth of new blood vessels by process of angiogenesis with fibroblast proliferation. Then granulation tissue matures into fibrous tissue with scar formation. Organization and scarring occur in the following conditions: chronic inflammation. Repair and healing in chronic inflammation is usually by fibrosis and scar formation. When there is excessive tissue damage, so repair and healing by fibrosis. When there is excessive fibrin deposition, so the replacement of fibrinous exudate is by fibrous tissue, which is called organization. And non-regenerating tissue, such as neurons, cardiac muscles, and skeletal muscles. So, repair and healing of injury in the brain, heart, and skeletal muscles is by fibrosis and scar formation. The fourth outcome of acute inflammation is progression into a chronic inflammation. Acute inflammation may progress into chronic inflammation when there is persistent causative agent or infection, or presence of the foreign body in the tissue. We start a new subject of chemical mediators and highlight only some of the more important mediators. Chemical mediators are substances which play a role in the inflammatory reactions. They are responsible for the main components of acute inflammation, such as vasodilation, increased vascular permeability, immigration of white PC as chemotactic agents, and humoral response. Types of chemical mediators. Chemical mediators may be produced locally by cells at the site of inflammation, or may be derived from circulating inactive plasma proteins, which are synthesized by the liver and circulate in plasma as inactive proteins. Then they are activated at the site of inflammation. So, there are two types of chemical mediators. First, plasma-derived mediators, which are plasma proteins, and second, cell-derived mediators, which are produced or formed by cells at the site of the inflammation. We start with plasma protein-derived chemical mediators. In plasma, there are four interrelated plasma systems, which are present as inactive plasma proteins. These interrelated plasma systems are Kinin system, complement system, Clotting system, and the fibrinolytic system. Activation of these four plasma systems produces inflammatory chemical mediators, which are plasma proteases or circulating plasma proteins. All these four interrelated plasma systems are activated by initial activation of clotting factor 12, which is called the Hagman factor. So, Hagman factor is plasma protein synthesized by the liver and circulate in the plasma as inactive protein. Activation of Hagman factor occurs by contact of plasma in the exudate with negative charge surfaces at the site of acute inflammation, such as collagen, basement membrane, bacterial lipopolysaccharide, foreign body, and proteolytic enzymes. All these structures carry negative charges. So, activated Hagman factor initiates activation of four plasma systems. Kinin system activation. The end result of Kinin system activation leads to the formation of chemical mediator, which is called bradykinin. So, bradykinin is a potent factor, causes first, increased vascular permeability, second, vasodilation, third, bronchospasm, and fourth, pain. Complement system. It consists of 20 cascade proteins that play an important role in the immunity and inflammation. Complement components, numbered from C1 to C9, are present in the plasma in inactive forms or inactive proteins, which are activated by two pathways: classical pathway and alternative pathway. Activation of complement system leads to the formation of, first, membrane attack complex from C5b to C9, which causes cytolysis, means lysis of microbes or bacteria, by lysis of cell membranes of the microbe or bacteria. So it is called membrane attack complex. Second, C3a and C5a. The letter A means active complement component, which are anaphylatoxins, have main actions in the severe allergic reaction called anaphylaxis. Both C3a and C5a cause increased vascular permeability and vasodilation by inducing mast cells to release histamine. Third, C5a is a potent chemotaxin or chemotactic agent for leukocytes. And four, C3b and IC3b. The letter I means inactive complement component, which act as opsonins and help in the cytosis. Activation of clotting and fibrinolytic systems occurs together. Fibrinolytic system activation converts plasminogen in the plasma into a plasmin by action of plasminogen activator. And clotting system activation leads to the formation of thrombin, which converting soluble fibrinogen into insoluble fibrin clot by action of the thrombin. Insoluble fibrin is converted into soluble fibrin split products which are called fibrinopeptides by action of the plasmid. So, the end result of activation of both clotting and fibrinolytic system is fibrinopeptides, which cause first an increased vascular permeability, second vasodilation, and third chemotaxis. We come to cell-derived chemical mediators that are produced locally by cells at the site of inflammation, such as macrophages, mast cells, endothelial cells, and leukocytes. First, vasoactive amines, which are histamine and serotonin, or 5-hydroxytryptamine. They are produced by mast cells, basophils, and platelets. They cause vasodilation and increased vascular permeability. Histamine is responsible for immediate transient vascular response or vascular leakage by inducing endothelial cell contraction of venules and formation of intercellular gaps. Second, prostaglandins and leukotrienes, which are arachidonic acid metabolites produced by mast cells and leukocytes and play a role in the inflammation and hemostasis. Prostaglandins cause vasodilation, pain, and fever. Thromboxane A2 causes vasoconstriction. Leukotrienes C4, D4, and E4 cause increased vascular permeability, and leukotriene B4 causes chemotaxis and leukocyte adhesion. So, the anti-inflammatory effect of aspirin and other non-steroidal anti-inflammatory drugs inhibit prostaglandin production and relieving pain and fever that are caused by prostaglandins. Third, platelet activating factor is produced by mast cells, platelets, and leukocytes. Platelet activating factor causes first vasodilation, second increased vascular permeability, third leukocyte adhesion, fourth chemotaxis, and fifth platelet activation. Fourth, cytokines are produced by lymphocytes and macrophages. The major cytokines in acute inflammation are interleukins, such as interleukin-1 and interleukin-6, tumor necrosis factor or TNF, and chemokines such as interleukin-8, while other cytokines such as interferon gamma are more important in the chronic inflammation. The functions of interleukin-1 and tumor necrosis factor are activation of endothelial cells, activation of fibroblasts, and induce systemic acute phase reaction that is associated with infection and inflammatory diseases such as fever, lethargy, leukocytosis, and other signs and symptoms of acute inflammation. Chemokines such as interleukin-8 cause chemotaxis. Fifth, nitric oxide, which is soluble free radical gas produced by endothelial cells and macrophages. The main functions of nitric oxide are First, vasodilation. Second, tissue damage. And third, microbial killing. Sixth, oxygen-free radicals or reactive oxygen species. They are released from neutrophils and macrophages. They include hydrogen peroxide, superoxide, and hydroxyl radical. The most important functions of oxygen-free radicals are: first, microbial killing, second, tissue damage, and third, increased vascular permeability. So, they are very destructive agents causing tissue injury and tissue damage. Fortunately, various protective antioxidants are present in serum and tissue to prevent the toxicity of these oxygen metabolites or reactive oxygen species. And these protective antioxidants are glutathione peroxidase, catalase, and transferrin. The last chemical mediators are lysosomal enzymes of leukocytes. Lysosomal enzymes are released from neutrophils and macrophages during phagocytosis and after cell death, including elastase, collagenase, and myeloperoxidase. The main functions of lysosomal enzymes are microbial killing and tissue damage. So, the harmful effects or damaging effects of lysosomal enzymes are controlled by antiproteases present in the serum and tissues, such as alpha-1 antitrypsin, inhibits neutrophil elastase. So, deficiencies of these inhibitors resulting in tissue destruction and tissue damage and causing diseases, such as alpha-1 antitrypsin deficiency in the lung, can cause tissue damage, resulting in a disease which is called emphysema. This slide shows the summary of chemical mediators. Vasodilation is caused by histamine, prostaglandins, nitric oxide, platelet activating factor, and bradykinin. Increased vascular permeability is induced by histamine, serotonin, C3A, C5A, bradykinin, leukotrienes C4, D4, and E4, and platelet activating factor. Leukocyte activation and chemotaxis are caused by tumor necrosis factor, interleukin-1, C3A, C5A, leukotriene B4, chemokines such as interleukin-8, and bacterial products. Fever is caused by interleukin-1, tumor necrosis factor, and prostaglandins. Pain is caused by prostaglandins and bradykinin. And the last is tissue damage, which is caused by lysosomal enzymes, nitric oxide, and oxygen-free radicals or reactive oxygen species. Thank you for your listening.